All right. So I'm just going to conclude here, and then we'll go further into the details of the test. But the current non-invasive assessment of CAD clearly results in a very low positive predictive value and many negative catheterizations. And I think this is very important in the context of cost effectiveness, et cetera. This is particularly important in the female patient population. I think I've shown you convincingly that the anginal symptoms certainly can risk stratify men with obstructive coronary disease, but they're not very useful in the female patient population. Whereas in men, typical and atypical symptoms of angina improve the positive predictive value of non-invasive tests. This clearly is not the case for female patients. And as I showed you, the false negative rates remain extremely high at about 25% in the PREDICT trial. So this Chorus CAD gene expression test is new. It's gender specific, as I mentioned, and it's based on a standard blood test. So as the patient comes into the office and you're kind of going through your algorithm and asking all your questions, the patient can leave the office having had this blood test drawn. The greatest value of this test, based on what I've shown you, is the negative predictive value. It's really excluding coronary disease, especially in women. So the negative predictive value in the male patient population was 76%, 84% in women, which is much higher than what we've seen with MPI, certainly by the C statistics in the context of this trial. Also, what I showed you is that Chorus CAD can reclassify patients after MPI. So I've shown you how weak in many ways the MPI tests are. 67% of female patients with a negative MPI and a high Chorus CAD score had obstructive coronary disease, so you can reliably send those patients to the cath lab, and that's probably the best thing to do for them. But on the other hand, only about 12% of women with a positive MPI and a low Chorus CAD test had obstructive disease, so you can really exclude patients if they have a low score. So I think, you know, in putting all this together, I think that this test is a new test without question. I think that there needs to be sort of an acceptability in the community, but clearly I think the data does support that it has a better ability to risk stratify patients with suspected coronary disease and avoid unnecessary diagnostic tests. All right, with that, we're going to move on to, I think, John, you're next up, and you're going to be talking to us about the validation of the test and some of the details of the clinical trial.